This is what we use if in terms of visibility. Yeah, truly endoscopy is very, nice. This is what I compared open surgeons with the endoscopic surgeons. We all know how to eat like this, but of course, if you want to eat like this, you have to acquire the skills, and this is what endoscopy does. When I started my endoscopic surgery, I didn't start just immediately on the human being. I first started with animal models because I know any small mistake, it can be very dangerous, and I'm alone. Nobody to help me. So when I make sure I dissect, this is me who dissected the spine of a ram, and then in my office, I make sure I have all what it takes to start. And then later I form a team, and then the team, we all got oriented, and then we became like a veterinary doctors. We're eating our patients after the surgery. We do barbecues. Now the aim of endoscopic interlaminar procedures, we all know it has least disruption of vertebral bone, least disruption of the spinal muscle, but you have a maximum or optimum outcome. What are the logics of endoscopic spinal surgery? How efficient is your surgical exposure? In 1977, Kasper, he advocated precise monosegmental unilateral access to the lumbar spine with minimal disruption of the spinal muscles to get access to the target. And of course, the efficiency of your surgical exposure is equal to the surgical exposure divided by surgical target. And here we can see the minimal exposure, but we get a very big target. Then before going into it, you have to know your anatomy very well. And the beauty of interlaminar approach compared to the transforaminal approach, if you are an open spine surgeon, you are already used to the anatomy going from posterior. That's the differences between the transforaminal. And then you have to know that the anatomy, it can vary, as you can see here. I had a patient where I didn't have the interlaminar window at all, and I was trying to go, interlaminar. And this patient, we can see the anatomy varies. Has interlaminar window, but even the left and right interlaminar windows, they are different. So you have to know your anatomy and all the variations. Anatomy again, anatomy, and now our talk is interlaminar, how to go from the roof. Again, why are we all, going into endoscopy? As surgeons, we know post-surgery pains is directly proportional to the surgical incision and then the intervention. This is a study that I did it myself, and I found out, yes, that's how it is. We can see here how minimum trauma endoscopy can be. Just a day post-op, and that picture, somebody, he had open spinal surgery, which was about 5 centimeters, but the small endoscopic I did for his reherniation, just 0.9 centimeters. And that's the beauty of it. It has a very clear vision. If you compare your eyes here, that is open or macroscopic or tubular, to your eyes, you are bringing it down here in endoscopy. This is the same, almost analog of a patient having macrodiscectomy, and that one is endoscopic. So you can see how clear the vision will be. I can say virtually no bleeding, minimal bleeding. And you have a very fast, quick recovery. Maximum and optimum patient satisfaction. The patients, they don't have to nurse their wounds, so they are happy with that. PELD using PSLD sets. These are the patients. The time when he came, he can barely walk, and then just.
So you are using the camera that's put in the hospital?
I know. And this is just 6 hours after the surgery, and you can see how happy the patient, is looking. You can see the misery in his eyes before the surgery. And that one you are seeing, he is our doctor. He is our ENT doctor. And when he came, we couldn't even recognize him because he was in severe pain. You can see from his eyes, he was in horrible pain. And now you can see how happy he was. And he went back to his duty the next morning. And the interesting part of it was that when we were operating him, he was saying, I have a patient to operate also. So just after the surgery, he left for his surgery also. That's the beauty of endoscopic spinal surgery. Then I thought of, before going into this endoscopic spine surgery, you have to know what we call 10 commandments and 7 sacraments. So I'm a Muslim, but I read Bibles. So I have to know my commandments and sacraments. This how the law is. 10 must know and 7 to do. 1, anatomical recognition of microstructures are very important. 2, despite the anatomical, disorientation when you started, you would get disoriented. But you should remember, it is the same anatomy. You are going into the same anatomy. And then attention to anatomical details is important. It's not like open surgery where, sometimes even you'll be struggling with the blood and then the anatomy might not be so clear to you. But in endoscopic spinal surgery, you must pay attention to every anatomical details. And you have to be calm. There's no need, especially when you are beginning, because you are in unfamiliar terrain and you might have a lot of surprises. And there must be hands-eye coordination. As your hands are moving, so also your eyes and hands should work together. And you have to be well oriented how you are going into it. And the power of 3D visualization is also very important in endoscopic spinal surgery. And you have to be extremely patient. And you should have less anxiety as you are going into it, because any small, impatient can cause a little havoc to what you are doing. And you must know your tools. Each and every tool you are picking, you have to know why you are picking it and why you are using it. And initially, it could be time-consuming, with the fear of handling the RF, drills, forceps, and the sharp instruments. But if you know it very well before, going into it, yes, then midlines and parallels. You have to know how to position your patient well. You have to know how to get, the image intensifier. You have to know how to have the whole parallels, parallel end plates, the midline of the spinal processes, and then the 7 components of PELD. Visualization of the target area with their image intensifier, hemilaminotomy or phlebotomy, the entering the epidural space, and identification of the lateral margin of the neural structures is very important. Just like the one we have seen, right, Professor Hura showed us, where we had the nerve damage. Probably the identification of the lateral margin of the neural structures were not efficient. And then the lateral recess decompression is important, and the retraction of the neural elements, and the ventral decompression of the neural elements. As you can see in this patient, this is a disc herniation just before the surgery. But you can see there, if somebody asks, this patient operated, you can hardly say yes or no. So this is how it goes. We are mobilizing the neural structures up here, and then here, the neural structures here, and then it got removed. Or in that case, we can see the nerve root, we can see the dura, and I put this picture. The disc is around this area at the lateral recess, and is getting mobilized, and this the lateral margin is getting mobilized, and now we are going to remove it. And one thing I do, I try to avoid using the sleeve to, retract the nerve. I try as much as I could do with the forceps to try to go into the lateral margin and then mobilize it and then go up and then bring out the disc. I feel like any retraction to the dura is a little bit traumatic also, from my own understanding. So this is how it goes, a big herniation. I think we can skip it. What do I need to start doing, PELD? These are the tools I need. And these tools, sometime I might need a drill, as you can see it here, but not always. If you have these tools, then you are good to go. And then with the tools, I can also decompress, contralateral, not only where I'm doing. In case of stenosis, you can compress this side, and then you can go into the other side for, as we can see here, we started from this side. This is the dura, and then we were decompressing the opposite side with our endoscopic set. And sometimes PSLD also, you can go into what we call direct to target. For example, this patient, he had a sequester, just a tiny piece of sequester, up-migrated. Translaminar, yeah. So I just went directly to the target, translaminally, and then I picked it out, and the patient is pain-free. We can see here, this is the lateral aspect, and then the neural structures are here, and that's where we decompressed. Also, using the PSLD, we do bone harvesting. We are living in a very resource-limited environment whereby the bone chips, they can be expensive. So instead of going to the market or to the shop to buy the bone chips, I harvest the bone chips using PSLD interlaminally. And then I go transforaminal to inside the cage. Like here, this one we took the bone graft, and this is how we insert. You can see it here. This is our interlaminar set. This is our transforaminal. So this is using the PSLD to take the bone graft. So it's very versatile. You can do a lot with it. This is bone graft we have taken, and this is the cage we were about to insert using PSLD. So benefits of PSLD set is versatile for interlaminar and translaminar procedures. All the same, we have to be a little cautious. Like here, we can see our RF is getting, detached, and this piece, it can stay behind. Or here, here our tool got broken, the piece of the tool. So you can have instrument breakage. Or here, the head of the cap also got detached. You can see, so we had to retrieve it. So if you are not so cautious, you can just leave it behind. It can be a source of infection. You can see here, just a small fragment got detached. So we have to be extra cautious while doing these surgeries. And then the reality is, as you are using your tools, you can damage it, and it can get, fatigued itself. So we have to know how to take care of these tools. I saw this thing. It is true. It is easy to look sharp when you haven't done any work. And of course, these are my tools. After doing some series of surgeries, for example, this I did more than 200 cases before it got broken. So in 200 cases, it became like this. I sent it back to Maximo, and I got exchange. And this I did about 50 cases. And it was accidental. I was teaching somebody, and then he hit the lens with a bone. And this is how it got broken. Of course, we have to manage our complications. As we can see it here, this is one of our complications. The nerve just came out, the part of the nerve, so during PSLD. And then we had one abscess formation out of about, I can say, 2,000 cases. This is the abscess we have. And Professor Hura, he said he never had any infection. Well, that's very commendable, but I had. I had one. And then this patient, we operated him, we didn't notice anything during the surgery. Then after about 7 days, he came back, he said he used to see some, fluid coming. And when he came back, then we found out, he was dripping CSF. But before the surgery, nothing was seen. So it can happen. And we didn't do anything for him. We just, gave him a bed rest. And then in about 7 days, he just ceased. That's how.
Also the good advantage for transfemoral surgery, because the pad of the liquor has to go through to come to the skin is much longer.
Yeah, then.
So I also never had CSF leak in endoscopic surgery
transforaminally. So that's it. And this is a reality. PSLD is a modern reality. It's one of our patients also. This is how he came. And you can see this how he was going, even trying to climb up. So endoscopic spinal surgery, PSLD, is the way forward. I was doing a lot of open spinal surgery before now, but when I started endoscopy, spinal surgery, I said, oh my God. And I saw this is my personal confession. Bless me, Father, for I have sinned. Last night I killed a politician. And he said, my daughter, I'm here to listen to your sin, not your community service work. So I hope my open spinal surgeries were just part of my community service work, not a sin. I wish to thank you all. This is Sebastian, and that is Yap, when they visited Nigeria. And we can see this Yap, Sebastian there. So we are very, honored to have you.